Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I have been a cardiologist in Houston for more than 40 years. The focus of this presentation is various types of premature atrial complexes, or as they are known as PACs. There's a difference between premature atrial complex, which is an electrical representation of the phenomenon, versus premature atrial contraction, which is the actual mechanical squeezing of the atria. So let us keep that difference in mind. So let us begin with the feature presentation. As you know, the heart is made up of two atria and the ventricles. Then we have the electrical system here, the sinus node, the AV node, and the bundle branch blocks in the Purkinje system. Normally, we have a sinus beat that is produced by the sinus node, which traverses through these conduction systems and produces the normal QRS complex. Occasionally, an ectopic focus from the atria can trigger an extra beat, which is shown here as represented by a normal beat, and an extra beat appears immediately after that, instead of the sinus beat, which is supposed to come somewhere around here, and it activates the atria and it goes through the normal conduction system, the AV node, the bundle branches, and the Purkinje system, and produces a QRS complex and T wave changes similar to the normal sinus beat. That is an important distinction we have to keep in mind when we are comparing that with a premature ventricular complex, which is going through the myocardium and producing a wide QRS complex with discordant STT changes. Not only that, the PVCs may or may not have a preceding P wave, or they can have a P wave following the QRS complex if there is a retrograde conduction of the impulse from the ventricles into the atria. So this is a premature atrial complex, and when you actually see the heart, then you see the premature atrial contraction. Let us look at some examples of a premature atrial complex and learn what are the various types of atrial complexes and what causes premature atrial complexes and what are their significances. Here we have a normal beat, normal beat, normal beat. Then we have a premature beat where the P wave morphology looks different from that of the normal P wave, suggesting this is an extra focus and arising from a different location from this other than the sinus node. Then we have a narrow QRS complex similar to that of the previous sinus beat. It is followed by a slight pause. Then we have a normal beat, an extra beat. Then it is followed by a slight pause. If you look at this RR cycle, this is longer than the regular RR cycle. If it is a PVC, you get a long compensatory pause, as it is called. But with PACs, we see a smaller compensatory pause because this is going through the normal conduction system as such. If the PVCs are occurring at a rate of like 3 to 4 per minute, they are called as rare premature atrial complexes or beats. If they are more than 6 or 10 per minute, then you consider them as frequent PACs. Even though the premature atrial complexes are considered to be benign, I, as a cardiologist, would not consider PACs as just totally benign. Yes, they can happen in 3 to 4% of the normal population. But remember, as we get older, the PACs become more important in significance for several reasons. Number one, you can feel these palpitations. For sometimes it is so annoying, they need to be on medications to control these extra beats, even if all the cardiac workup is negative. Number two, these PACs act as the trigger mechanism for the introduction of paroxysmal atrial tachycardia or atrial flutter. So it is very important to understand those PACs, as benign as they may look, but they are the precursors of paroxysmal atrial tachycardia or atrial flutter or they can even trigger atrial fibrillation. So let us keep some of these important points in mind, because we need to work up PACs as vigorously as we do with the PVCs. I have a separate video on premature ventricular complexes, various types, and how you recognize them. And there I talk about all the different causes of premature extra beats. The same principles apply to premature atrial complexes. Please take a look at that video so you get a much better understanding of how to deal with these patients, more importantly, in addition to recognizing their diagnosis. Here is an example of an abnormal morphology. Let's start off with normal beat. Normal beat. There is something here right at the descending limb of the T wave. Okay, let's keep that in mind. Let's march on. Normal beat, normal beat. What could this be? This could be an extra atrial beat. This is an extra atrial beat, but we don't have a following QRS complex. So what does that mean? It means we have an atrial premature beat which was blocked. It could not conduct through the AV node to produce the QRS complex. How could it happen? It could be in the absolute refractory period. That is, the AV node is refractory. It is not responding to anything. As a result, that impulse may be blocked. However, whenever we see a blocked P wave, it doesn't always mean it is a blocked P wave because of the refractory AV node. It could be part of the sinus cycle itself if these P waves fall exactly at the same intervals, and it may represent an arrhythmia, cardiac arrhythmia, which I'm going to talk about in a minute. So keep in mind these blocked PACs are very important to differentiate as what is causing the blocked PAC. Now here we have an example of a normal beat, an atrial premature beat. How do we know this is an atrial premature beat? First of all, we have a P wave here, which looks different in morphology from the previous one, but nonetheless, there's a P wave. We have a QRS complex and the T wave, which looks similar to the sinus beat. So we have a sinus beat, PAC. Sinus beat, PAC is cut off here. So this is known as the atrial bigeminy. That means every other beat is an extra beat. That means half of your cardiac cycle is produced by extra beats. Actually, atrial premature beats do contribute to the cardiac output, whereas ventricular premature beats do not generate any significant stroke volume. So let's keep that in mind. So if you get like two PACs in a row, it is known as the atrial couplets. If you get three, it is known as the atrial triplets, which I have explained this in that PVC's video more clearly, and you can look at those things. And now let's look at the concept of blocked P waves. Remember, I told you whenever you see a blocked P wave, you need to always think about where is the P wave falling, and is this part of the regular sinus cycle or is it different? Now let's look at here. You have a sinus beat. Now we have a sinus P wave. We have a sinus P wave, and we have a P wave here which is dropped. Is this a blocked PAC, or is this part of a rhythm problem which is known as Wenkebach? Wenkebach is, there's a whole book written on Wenkebach, but I'm just going to simplify. Wenkebach is where there is progressive prolongation of the PR interval at the AV nodal level, where the AV node gets fatigued with each heartbeat. As a result, finally it says, I'm too tired, I can't transfer any more impulse here. So that P wave is dropped. And look at some of the characteristics of Wenkebach. The P wave morphology is identical. The PP intervals are identical. The RR intervals shorten with the succeeding cycles. And more importantly, the PR interval gets longer, drops. And the preceding one is shorter than the PR interval that occurred before that blocked P wave. So not all blocked P waves are blocked PACs. It could be part of the Wenkebach cycle. What more, it could be an advanced heart block, like here we have a normal beat, normal beat, normal beat, P wave dropped, and a normal beat. But if you see more than 2 P waves blocked, then you may be dealing with a high-grade AV block. And the Mobitz type 2, the only way you can find out is to make sure that the PR intervals are constant as opposed to the progressive prolongation of the PR intervals in the Wenkebach type, Mobitz type 1 block. Whereas we have, when you get just normal beat, block beat, normal beat, block beat, we don't know if it is Wenkebach or Mobitz type 2 block. That's something you keep in mind. Similarly, with a complete heart block, we can see multiple P waves blocked, and some of them may be conducted occasionally through the AB node, in which case it is called the high-grade AV block. Now, here is an example of a normal beat, extra beat, pause, normal beat, extra beat, normal beat, extra beats. So this is like a atrial trigeminy. Whenever we see any atrial trigeminy, we should always think about what I told you, any type of conduction disturbances like Wenkebach. We have a normal beat, may look like an extra beat because it comes a shorter cycle than this cycle. So keep in mind some of these differences when you're looking at the tracings. Now here is an example of a long PR interval, longer PR interval, much longer PR interval, much longer PR interval, and a P wave that is dropped. A good diagnosis would be a Wenkebach. Again, you need to think about what is the differential diagnosis. Is this a blocked PAC? If it is blocked, it has to be premature. That means you measure the PP intervals. If they are constant, then you are dealing with a Wenkebach. Is this type 2 Wenkebach? No, because you got a progressive prolongation of the PR interval, which suggests this is the Mobitz type 1 Wenkebach type block. And here we have a normal cycle. Then we have 1, 2, 3, 4, 5 extra beats happening at a rapid rate. This is known as the short bursts of PACs. The short bursts of PACs could be, depending upon the rate, could be just extra beats, or it could be short burst of paroxysmal atrial tachycardia, which is anywhere from like 160 to 220, or it could be a short burst of atrial fibrillation where the RR intervals are going to be grossly irregular from cycle to cycle. So whenever we see a short burst, we should think about so many different things. Now you understand as why I say PACs are as important as PVCs, because they could be precursors of paroxysmal atrial tachycardia, atrial flutter, or even atrial fibrillation. Now, whenever we see a heart rate between 125 and 150, we have a narrow QRS rhythm. It could be sinus tachycardia. It could be supraventricular tachycardia, like if you put somebody on a treadmill, you can get rates up to 160, 170, 200. It could be paroxysmal atrial tachycardia with a P wave QRS between 150 to 180. Or it could be atrial flutter with 2-to-1 conduction. See, I matched the cycle length, and if you see here, you have a P wave QRS, 1P QRS, 1P QRS, 1P QRS. But here you have two waves, atrial waves for each QRS complex. So this is atrial flutter with 2-to-1 conduction versus paroxysmal atrial tachycardia here. So keep in mind, whenever you see a rate between 125 and 150, always think about sinus tachycardia, supraventricular tachycardia, or atrial flutter with 2-to-1 block. Your flutter is between 225 to 320. Atrial fibrillation is greater than 400. Sometimes we get multifocal atrial tachycardia, which is commonly seen in patients with chronic obstructive pulmonary disease. That's the only condition where you see that most often, and the P wave morphology varies from beat to beat, and it looks like atrial fibrillation, but you see distinct P waves of different morphology. Carotid sinus pressure is extremely useful in diagnosing the underlying atrial rhythm in patients with this rate between 125 to 160, I would say, to see is this sinus tachycardia, is this paroxysmal atrial tachycardia, or is this flutter with 2-to-1 conduction. When we do a carotid pressure, it blocks the conduction through the AV node, and it might unravel the flutter waves if they are, but if it's a case of a paroxysmal atrial tachycardia, it may even terminate the paroxysmal atrial tachycardia. That's why some people with paroxysmal atrial tachycardia have learned to use vagal maneuvers to slow the heart rate down to a point where it may terminate the paroxysmal atrial tachycardia. All right, here is the same example of atrial flutter with 2-to-1 conduction, and whenever you see this sawtooth appearance in the electrocardiogram, whether you're taking ACLS or EKG exam, think about atrial flutter. And when you think about atrial flutter, you have to think about the ventricular rate also. Here's an example of an irregularly irregular RR intervals. Keep in mind the words which I said, irregularly irregular RR intervals. There are very few conditions that cause irregularly irregular RR intervals. It could be frequent PACs, it could be frequent PVCs, or it could be multifocal atrial tachycardia, or it could be atrial flutter with variable block, or it could be atrial fibrillation. Most often, the reason for an irregularly irregular RR intervals is atrial fibrillation. And whenever you see a patient with irregularly irregular RR intervals with a wide QRS complex, don't jump up and say, oh my God, this is ventricular tachycardia, let's give some lidocaine. That's the last thing you want to do. You want to first diagnose what is happening with this patient. If you have a previous electrocardiogram, look at their electrocardiogram and see, does this patient have a bundle branch block to begin with? Or does this patient have a WPW, Wolff-Parkinson-White syndrome? So that is a situation where we can see wide QRS tachycardia, especially atrial fibrillation with varying RR intervals, which very much mimics ventricular tachycardia, but generally ventricular tachycardia is more regular, and you may see some fusion beats. But most important thing is that whenever you see a wide QRS tachycardia, think about bundle branch block, underlying bundle branch block, or WPW. So ladies and gentlemen, this is a very quick synopsis of atrial premature beats. Atrial premature beats are of great significance just as the premature ventricular complexes are, because they have the same reasons as to why they happen in a person, and atrial premature beats are of significance because they can trigger paroxysmal atrial tachycardia, atrial flutter or fibrillation, and they can be annoying to certain people. So hopefully this will get you some education as to what are atrial premature beats and how you identify them. And please do watch the video on various types of ventricular premature beats, where I talk about the causes and how to diagnose what is the underlying cause of these extra beats. And please do subscribe to our YouTube channel. I will see you in the next video. Thank you so much.